Schumann. I have the privilege of co-chairing the clinical ethics service here through the Center of Bioethics and Social Sciences and Medicine. And we have a special treat today in that we're going to have a multidisciplinary panel discussion of a topic that is germane and relevant to really everybody who works within the Michigan medicine system and healthcare in general. The order of business is that we'll have 3 short presentations followed by a panel discussion. I will moderate the discussion afterwards, and I'm going to introduce all 3 speakers right now, simply to assist with flow over the course of the hour. Our first speaker will be Susan Burgess. Ms. Burgess is an advanced practice registered nurse who works with the Psychiatric Consultation Liaison Service at the University Hospitals, as well as the lead for adult behavioral consultations here. She also is one of the authors of our recently revised restraint policy, and will be presenting the perspective both from policy at University of Michigan as well as through her work in the day-to-day consultant role that she has clinically. We also have an esteemed guest and colleague from across the state joining us. Dr. Tyler Gibb is an assistant professor and the co-chief of the program in medical ethics, humanities, and law, as well as the vice chair of the IRB at his home institution at Western. He has a PhD in healthcare ethics and a law degree, both from St. Louis University through a joint degree dual program, of which he, I think, was one of the pioneers. His research is really at the intersection of health law, ethics, and clinical care. He's done work in professionalism, medical politics, pedagogy, as well as neuroethics. In his clinical role, he is the primary clinical ethicist for 2 large complex institutions on the west side of the state, and has been our collaborator and colleague on a number of initiatives across the state with regard to clinical ethics. Finally, Dr. Colin Cooke is an associate professor in the Department of Medicine in critical care. He is also a member of the IHPI and a critical care physician and health services researcher. His work really looks at the intersection of policy, care, and system, and specifically works on how individual patient characteristics shape efficiency and quality of care delivery in the intensive care unit. So all 3 bring fairly different but important perspectives to the issue that we're going to be talking about today. We will invite discussion, comments, questions from the audience as soon as we've heard from our presenters. Let me make sure we have the right presentation up. Maybe. Stay tuned. Okay, here we go. So none of us, to my awareness, have any conflicts of interest or disclosures. And without further ado, I will turn it over to Susan. Thank you so much for joining us.
Hi, good afternoon. Everybody can hear me? Good. So as Dr. Schumann explained, I'm an advanced practice nurse, and usually I get called in when there's a barrier to care. That's always the first question when I arrive. Is there a barrier to delivering this patient's care and getting them the outcome that we want them to have? So we have 2 current policies within Michigan medicine. We have a nonviolent and a violent. This is a challenging topic, right? None of us want to restrain a human being. But we want to do it when we use this as a tool, which we do here at Michigan Medicine. We want to do it in a really conscientious way to promote safety, promote great outcomes, and then the best for the staff and the patient and the family. And when we do this, and these are for your reference for later, when we do this, we want a good intent, right? That's always our goal. We want to do the best by the patient. We want to do the best for us and the best for their family. And we don't take these topics or conversations lightly. So I'm really looking forward to the discussion. So we have 2 categories where we decide at the time of order nonviolent or violent restraint for that patient, depending on the circumstances. So what we always want to keep in our mind is what behavior are we trying to help avoid? So if that's a nonviolent behavior, they're trying to kind of pull at their lines and drains and tubes that could cause significant harm to them if they did, that's the nonviolent. So a lot of times we get kind of hung up on what restraint are we putting them in. So not necessarily do we have to, every violent is a locked limb restraint, right? So we want to think about the behavior that we're trying to stop. We're trying to help them with that piece. So you can see the violence, as we know from clinical practice, that's where it's a danger to the patient or others. That's the violent. Everything else is nonviolent. So this is our last resort intervention. We want to try everything else first, right? That's where our good intent comes from. That's where our professional practice comes in. We want to make good choices for this human, and we want to make them with a lot of consideration, and we also want to try tons of alternatives before we get to this intervention. We've got distraction items, my service. For those that are like delirious or pulling at lines, we have these little kind of stretchy yo-yos, and it's like tons of little lines all clumped together. And so if they're kind of a picker or they're pulling at like an airway, that sometimes gives them a good alternative. We have sleeves, we have family at the bedside, we have video monitors, we have patient attendants and rounders. So we're trying lots of different things, even hiding lines under blankets sometimes, right? Sometimes we get really creative trying to kind of find an alternative. So these are the things we want to consider. We want to weigh out the risk versus benefit. We know there's risk that comes with restraints. We have to choose in those clinical moments, the provider's choosing, is this benefit worth the risk of the restraint? So if we decide that it is, we also have to think about reasonable care. Is this reasonable care we would give to a similar person in a similar circumstance? We never want bias to be part of this decision making, right? We want it to be as objective as possible with the safety and good of that patient in mind. So these are always acute life-threatening, kind of reversible situations, and we're never going to use this for long-term chronic care. If we see that a patient is trending in a way that they're getting to put in restraints often, a lot of times back to back, we've got to dig in a bit. We've got to find out what's up, what's happening, what other things can we be doing? Did we miss something? What else is going on that we're kind of going back to this alternative? Because that's not what we want. So guiding principles, this is kind of the nuts and bolts, right? My work here today, this quick 10 minutes, is to just give us a rundown of where we are. The guiding principles are good. These are the rights of the patient in our system, in our care. So we want them to be free of restraint. That's the ideal goal. We want them to be in a safe environment with minimal discomfort and pain. We want it to be a safe, appropriate technique. That's why we do tons of training on how to do this, when to do it, why are we doing it. And then we're not using chemical restraints. We're not using an agent to restrain in lieu of a physical. And then any personal items, and this is straight out of the policy, any personal items that would kind of hinder the restraint or make it less safe, we take that too. So our priority in general as a health system, of course, is to minimize restraint use, right? That's the goal. We don't want to do this. Do we use it as a tool? Yes. Is it one that we want to go to work and do? No, it isn't. So luckily, between fiscal year 17 and 19, we decreased violent restraint use by almost 40%. So that's a big movement. There's lots of teams in place. The Bridge Group, I don't know if you guys have heard of that yet, that's up and coming, and it's about cultural change and change around workplace violence and these kind of behavioral topics. So there's lots of good work to do. Lots of good work already happening. So as far as implementation and clinical practice, this piece is also why I get called in sometimes. We have providers that just aren't totally comfortable always ordering restraints because they don't do it very often, right? So that's a good thing to get called on. It's either like a clarification of what the order set needs to look like, what the time parameters need to be. And we also, our team addresses like the staff and faculty tolerance. Behaviorally and ethically and medically, everybody's tolerance is different. We expect that, right? We all have our individual practice, but collectively, we want to decide in those moments, is this a tolerance issue? Is this a medical issue? Is this a safety issue? And that's what's going to drive us. We always want to be talking about parameters for discontinuation. That should be a conversation from the moment the restraint is ordered, and then we're working toward that goal throughout. And then colleague and family influence. This is kind of a funny one for me because I've been called on consults where I arrive and the family wants to preventively put the patient in restraints. We can't do it. We cannot do it. So we talk to the patient. That's where the education comes in. We talk to the family. And that's where the the education comes in for the family member that, yes, we understand the history. Yes, we understand how this hospitalization course looked last time, but we can't do that this time. And so we have to be kind of firm in our stance about how we use this intervention and use it wisely so we don't get influenced in those moments by family members and significant others. That's when I see it the most. So we all want safety for our patient. But with this comes distress, right? There's real distress that comes with this intervention for many. That's also where we get called in, that staff support piece. It doesn't make us feel great a lot of times to do this to a person, even though we know they're in an ICU and they're delirious and they're at risk to themselves, and it's a real risk. It still doesn't always sit with us so great. So collectively, again, with the culture of our system, we kind of focus on how do we keep patients safe in these really complex layered cases that have a lot of nuances where we really want to do the best for everybody. And everybody, as you can see, kind of experiences sometimes some emotional distress around these cases. So this is where we are. This is where our institution's policy and procedures kind of sit today. We do use restraints, and I implore you to use them conscientiously. So that's the end of my piece.
Dr. Gibb?
Yep. All right, thank you. So I was encouraged to be ready for some hostility when I came to Michigan. So I'm encouraged that the policies are thoughtful here. I'm encouraged that the approach and the way that we deal with restraints are done in a way that respects both the integrity of the profession of medicine, but also the rights and obligations we have towards our patients. So my goal, and if I'm successful in my goal, you will all agree with me by the end of this, and we'll be able to maybe just go out to lunch afterwards and talk about Michigan football. Apparently there's a game this weekend. I don't know. So we'll see. Okay. So no financial conflicts of interest to disclose. And this is the question. What are the necessary and sufficient conditions for the application of these restraints? And so this is my job often as I tell my colleagues who consult clinical ethics consultation service is that if you have a 30-second problem, I can talk about it for about 30 minutes. And if you have a 30-minute problem, my job is to be able to distill that into about a 30-second response. And so this is the former, where we had a student who came and spoke with, or he came and actually did a clinical ethics elective with us and spent 2 weeks going on all of our clinical ethics consultations. And he was troubled by what he saw in some of the ICU situations. His concern was that restraints were being applied too often and for too long and without careful thought about when and how to do that. And that prompted further investigation by Dr. Crutchfield, who's one of my colleagues and the lead author on a paper that we published recently, and has created a lot of conversation. And I think it's something that bears a little bit more, I would say, maybe a step back and a little bit more theoretical, analytical approach to it. So that is our question. This is the paper that we published in CHEST, and again, this is intended to be a fairly brief overview of this paper, but it's well footnoted, and I'm not going to go through all the details of the argument in the paper. So I encourage you to read the paper if you want. So this is the foundation of a lot of what we do, right? So the conditions for the ethical use of medical interventions, regardless of what they are, you can substitute any way in which you touch or interact with a patient. They must meet these three criteria. Informed consent must be obtained. Treatments must be medically appropriate. And treatments must be the least liberty-restricting or harmful means of achieving the medical aim. So here are some foundational assumptions that we have going into our work, looking carefully at restraints. So first, liberties, regardless of what liberties you have. And again, I'm a lawyer by training, so I may be using the word liberties in a nuanced way, but liberties ought not to be infringed upon without at least some sort of minimal justification. It could be a very superficial justification, but some justification has to be in place. Number two, or the second one, basic liberties, or foundational liberties, are those which are required for living the life of a free person, a fully encapsulated, empowered individual within our society. Anything that is necessary for achieving life, liberty, the pursuit of happiness, we refer to in the paper as basic liberties or fundamental liberties. An infringement upon those liberties to demand a correspondingly strong justification. So think about if you have ever been arrested, there are certain requirements, certain justifications that the police or the law enforcement have to have in order to restrict your liberties. Thirdly, controlling one's liberties, or controlling one's person, one's body, specifically healthy functional limbs, is required for living the life of a free person, and thus a basic liberty. My prerogative to move my body in any way that I want to is a basic fundamental liberty. Infringement upon that liberty demands a correspondingly high justification. And then finally, the application of any mechanism or restraint which inhibits a person's ability to control one's otherwise functional limbs demands a correspondingly high justification. But as we know, liberties are infringed upon all the time. Even basic liberties are infringed upon all the time. So restraint of movement, so imprisonment, incarceration. Restraint against action of other people. So we have criminal laws or tort laws, civil laws that restrict our ability or apply significant penalties when we use these basic liberties inappropriately. We have restrictions on the freedom of speech. Also, liberties are limited in the medical situation, in the healthcare setting. So free restraint of movement. So somebody who comes into our psychiatric units and has the petition and certification completed appropriately, their ability to leave that unit is restricted, but we think it's justifiable in certain situations to do so. Similarly, freedom of movement is restricted during quarantine situations. This is more of a social public policy justification for your ability to move and interact in a way in which you may desire to do so. And the justifications are similar to what the justifications are for the policy that was explained by Susan just a moment ago. The justification for the restraint of free movement, retribution, punishment, the incarceration situation, also to prevent harm from other people. We restrain our ability to move, act against other people, again, to prevent harm. Generally, it's to prevent harm to self or to other people. And in order to achieve that goal, which is a laudable goal within our society, we restrict people's liberties and also their basic liberties. So if freedom of one's person is a basic liberty, what are the necessary and sufficient conditions for restraining that liberty? And we don't presume that our patients give up those basic liberties just by virtue of walking through our front door. They retain almost all of their basic liberties. But that doesn't mean that we have no option to restrict those at some point. So here are a couple more assumptions. All other things being equal, being restrained is a less desirable condition than being not restrained. Me having access to my basic liberties is a better state of affairs than being restricted. A medical treatment or intervention is an action which has at its aim the improvement of a patient's health or the prevention of an avoidable harm. Application of physical restraints, and I'm limiting, our conversation is limited to physical restraints. I think chemical restraints are a little bit more complicated, and so we're just going to kind of set those aside for now. But physical restraints in the healthcare setting ought to be considered a medical intervention or a treatment, probably more of an intervention. And unless justifiably exempted, which we'll talk about in just a moment, medical treatment or interventions, regardless of what they are, ought to be consented to by the patient or a legally authorized decision maker. So again, we go back to the first set of conditions for the ethical use of all treatments or interventions. They should be consented to, they must be medically appropriate, and they should be the least liberty-restricting means of achieving that medical aim. So if you grant the proposition that the application of medical restraints or physical restraints are a medical intervention, we can just merely substitute the word restraint for the medical intervention. Informed consent must be obtained for restraints. Restraints must be medically appropriate, and they must be the least liberty-restricting or harmful means of achieving this medical aim. So the first condition, physical restraints must be consented to, or the requirement of a consent must be justifiably exempted. These are the classic situations in which informed consent from an informed patient, a capable patient, are exempted by law. So in an emergency situation, the requirement for getting treatment consent is exempted. A therapeutic exception. So this is when the process of the informed consent discussion or the conversation will actually cause more harm to the patient, a disproportionate amount of harm to the patient. Generally, this is in the psychiatric setting, where somebody, for example, would have a profound anxiety, or our concern is that the disclosure of a certain diagnosis or a certain set of conditions would be harmful to the patient and send them off into a situation which is avoidably harmful. There are two other situations in which informed consent may not be applicable. If the patient capably waives their rights to informed consent, and then a new idea be in the literature about whether a placebo situation may exempt somebody from getting informed consent. The idea being that if the benefit of the treatment would be undermined by the informed consent process, then there may not be a requirement to get informed consent. Often we hear about this, the idea of implied consent or presumed consent. And that's a little bit different. Implied consent requires that there's some sort of basis of fact or basis of information upon which an implication can be driven or derived. And so in most cases, these exceptions do not have an implication of consent. It's a different type of rationale. It's a presumption of consent rather than an implication. And if we're presuming consent, it can only be presumed if a reasonable patient would not find the information disclosed meaningful in making a decision whether to adopt the medical recommendation. Or to put another way, more generally, that the acceptance of the medical treatment or intervention is something that a reasonable patient would not refuse. And so we can presume, all other things being equal, that the person we can presume that they would give consent to that. All right, number 2, physical restraints must be medically appropriate. This caused a little bit of consternation when we were going through the peer review process of this article. One of the commentators said, well, clearly restraints are effective and clearly they reduce the harm because it disallows a patient from self-extubating. And the comment actually that came back was, we don't have to do a double-blind controlled study to prove that parachutes are effective, which seemed a little bit glib and missing the point. But the medical literature demonstrates or shows us, or at least implies to us, that maybe that's not quite as clear-cut as we think it is, or the assumption is. The rates of self-extubation and the harms of patients who are physically restrained in the ICU setting, if anything, the data is ambiguous. And if there's ambiguous data, then a strong justification, I think, can be made for either we need more data or we need to err on the side of protecting somebody's basic liberties. Number 3, physical restraints must be the least liberty-restricting means of achieving their medical aim. I think the policy that was described talks about all of the different ways in which we can avoid physical restraints, but also achieve the same means. And physically restraining our patients ought to be our treatment of last resort, as was said. So the alternatives, again, as was mentioned, sitters, more family involvement, distractions, increased nursing staff, chemical restraints, again, we're going to kind of bracket to the side. So circling back to the conditions for the ethical use of restraint, they must be consented to. And if there's no emergency, if there's no waiver of consent, then is there a harm in involving either patients or legally authorized decision makers in a consent process when we're talking about procedures which have the likelihood, or at least a reasonable expectation, that they will result in an intubation? It is not our position, nor do we argue, that restraints are bad per se. They're useful in certain situations, but it's very uncommon for it to be an emergency situation. If there is an emergency, somebody is acting out and physically violent, then of course, then there's justification for it. But if it's something that we can anticipate, or at least it's not unreasonable to expect that somebody may have a respiratory decline where they need to be intubated, and part of that intubation process may involve restraints, then is there a harm to including the possibility and the ramifications of being restrained in that informed consent process? So I'll end there. Again, so this is the citation for the paper that came out in Chest in the spring. And then I look forward to the conversation and questions, whatever may be. So thank you.
Great, thanks very much. My name's Colin. I'm an intensivist here at the University of Michigan. I work in the medical intensive care unit here. And while I do serve as a member of the Adult Ethics Committee, I'm not an ethicist. So I'm approaching this topic from the perspective of a clinician, but also from somebody who has built a career around doing observational research around systems. As Dr. Gibb highlighted, this is the paper that I think that sort of is the focus of our discussion today, that Dr. Crutchfield authored with Dr. Gibb and others. And in this manuscript, and as we've heard in the prior presentation, there are a number of statements sort of backing the argument that that supports their conclusion that the use of unconsented physical restraints on patients is not ethically permissible. And the primary focus of those arguments relies on consent and challenges with informed consent, specifically in patients that don't have capacity. As we've heard, there's been some highlight of equivocal evidence around the benefits and potential harms associated with presence of restraints or the absence of restraints. Specifically, the literature suggests that the harms due to self-injury may be overstated, and that there's really an absence of evidence suggesting that restraints are not clearly beneficial. And then there's also some discussion in the paper that we also briefly discussed in the prior presentation, that the typical exceptions to providing informed consent in the intensive care unit generally don't apply in the context of restraints. Specifically, that emergency treatment is not applicable in the majority of cases of restraint use, and that consent cannot be presumed. So I'd like to kind of briefly touch upon these arguments from the perspective of an intensivist who works in the ICU to kind of provide an alternative framing of the conversation. So while restraints are generally used in the ICU for many different reasons, perhaps the most important one, the most relevant one, has to do with restraining patients that are mechanically ventilated. Mechanically ventilated patients are quite common in the intensive care unit. Perhaps about 16% of all ICU admissions are patients that are on mechanical ventilation. Generally, patients that receive mechanical ventilation at some point during the process are agitated. They can report discomfort or pain due to the endotracheal tube insertion or placement. They're often disoriented, and together these sort of form this constellation of symptoms of delirium, in up to 85% of patients that are mechanically ventilated. So generally, majority of these people, though not all, lack decisional capacity, and so we have to turn to alternative measures when we are trying to seek consent for procedures and other interventions. Almost all of these patients are sedated. They have some sort of what would be perceived as a chemical restraint in some context. That may not be continuous, but certainly around the time of endotracheal intubation, patients do receive some sort of sedative. I think that discussion about physical versus chemical restraints is very interesting, and I think we could have an entirely different discussion about how our transition away from using medical restraints has increased the prevalence, perhaps, of physical restraints, but we can perhaps save that for the panel discussion. Mechanically ventilated patients universally have a high mortality, although it's probably less than this. In non-surgical patients, up to 30% of patients that receive mechanical ventilation may die during their hospital stay. And in generally, mechanical ventilation is initiated because the physicians or the providers caring for the patient believe that the patient will have a much higher rate of mortality without the mechanical ventilator being implemented. Whether or not that's 100% is probably not quite there, but certainly higher than 30%. And then about 5 to 20%, depending upon the prevalence or incidence estimates you look at, 5 to 20% of ICU days for mechanically ventilated patients are spent in some sort of physical restraint. Unintended extubation is really the main reason why restraints are used in patients that are mechanically ventilated. This is defined really as the unintended removal of an endotracheal tube during mechanical ventilation. Generally, while unintended extubation can occur for lots of different reasons, the most common reason it does occur is because of self-extubation. This is where a patient either intentionally or unintentionally grabs the endotracheal tube and removes it during mechanical ventilation. Actually, prevalence estimates of this are quite robust, and many of the randomized controlled trials looking at sedation use in mechanically ventilated patients suggest it's anywhere from 3% of all ventilated patients self-extubate. It's idiosyncratic and that it's difficult to predict, although there are some predictors that have been shown in the literature. They vary across studies. It is associated with some unintended consequences or adverse problems such as laryngeal edema, laryngeal trauma, bleeding in the upper airway, and there are cases of patients dying from accidental extubation. Interestingly, only half of self-extubations ultimately require the endotracheal tube to be replaced. This is in large part because we are terrible as ICU clinicians at identifying patients that are capable of breathing on their own. Turns out when patients pull their tube, only half of them have to have it in the first place. But it's very difficult for us to predict who are the ones that are going to need the tube or the ones that will fly without it. So when we're speaking about the evidence, what are the evidence suggesting that restraints may be harmful or beneficial, or are there really harms to self-extubation? And in reality, without going into too much detail, the harms of self-extubation, the literature is universally bad. And this is coming from somebody who's built a career around observational science and health services work. The vast majority of this work is observational or case-based series. So to really understand what is the harm of self-extubation, it's quite difficult because we typically don't follow patients long-term without doing something to them once they self-extubate. And this is in part a challenge due to the rule of rescue, which is sort of a bioethical construct that is used in many different contexts, discussing where when physicians see a patient in extremis, we typically intervene. So when patients self-extubate, if physicians see abnormalities in their vital signs, typically we intervene because we feel as though something needs to be done. And there are cases that we say in 50% of the time, patients do fine, but following the natural history of self-extubation to determine whether or not there's an attributable mortality to it is quite challenging because of this process where physicians typically intervene in people that look bad. We do know that about half of people who are self-extubated do require reintubation, which, according to the physician, is necessary in order to sustain life. The literature around the benefits of restraints is also universally bad. It's all observational and case series. There are some very small RCTs, but typically not terribly generalizable to a larger population of people. And I think one thing that's important to note is that these studies are heavily, heavily confounded by indication. So if you look at the vast majority of studies of observational work that looks at the benefits or harms of restraints, they suggest that actually having a restraint in place increases the risk that a patient will remove their endotracheal tube. This is largely a function of the fact that the reason we put restraints in place is because the physicians or the providers feel that the patient is at high risk for self-extubation. So we're not able to fully adjust the differences away. If we switch the context of this discussion and we say, do we believe that patients admitted to the ICU are more likely to die? The answer is yes. So is ICU admission therefore causing those patients to die more frequently? No. The reason why we admit those patients to the ICU is because we believe they're at greater risk for death. This is the same challenge with the observational research around restraints. The greater risk of self-extubation due to restraints is not actually causal, it's purely a correlate because we put restraints in people who we believe will self-extubate. So I don't believe the literature that supports that the restraints may be harmful. I think that that's bad science. So without grounds for good empirical data, we're then left with having to make clinical decisions using other warrants for decision making, specifically things such as experiential evidence, things that I practice, what has been my experience when I'm in the ICU. Is there a pathophysiologic rationale for putting restraints in place? Do we think that having restraints is consistent with the patient's goals and values that they've articulated when we're providing care for them? And are there system level issues that we need to incorporate when we're thinking about making decisions? Do we have the capacity as a hospital to be able to support sitters in all of our patients who need them? So these are the things that I turn to when I'm in the intensive care unit and I think about whether or not restraints are beneficial. And I think that from an experience perspective and from a pathophysiologic rationale, and often from a patient goals and values, I think those warrants for decision making in favor of restraints are often present. With regard to the exceptions for consent, so can emergency treatment be applied in the context of consent for patients in the ICU? So critical care generally is defined as use of life-sustaining technology or individuals who are at risk for life-threatening deterioration. And so it's arguable, although not all may agree with this, that a patient who is deemed as critically ill lives in sort of a state of controlled emergency, right? The reason we move patients to the ICU is because we believe greater monitoring may be able to either avert deterioration faster or may prevent deterioration. But the purpose of being there is actually to help control sort of the sustained emergency. Adverse events in the ICU, including self-extubation, is often idiosyncratic. There's plenty of case reports of patients having sitters in the room who self-extubate. It takes 2 seconds for a patient to reach up and grab their endotracheal tube, not long for a sitter to be looking at their phone without noticing. Can we presume consent for restraints? This was discussed in the prior presentation. And I think in general, from a perspective of a provider, if an individual has gone ahead and consented, or their surrogate has consented to admission to the intensive care unit, if they've consented to mechanical ventilation, if they've essentially consented to be immobilized in their bed during their intensive care unit stay while they're on the mechanical ventilator, although this is not universally the case, and if they've also generally consented to other routine medically necessary treatments in order to save or prolong life, such as urinary catheters, intravenous access, central venous catheters, and so forth, things that are commonly done in the intensive care unit. I believe that medical restraints in certain patients are part of this package of good care that's necessary for us to be able to achieve the goals that patients articulate, which is to save their life and to prolong life. So I think that in many settings, we can assume that consent for these restraints is part of the medically necessary care in order to prevent patients from self-extubating. So, as I said, I think that it's reasonable to presume patients are willing to accept restraints that are deemed medically necessary to achieve the same goals with the greatest probability. So my own personal views on restraint use, that I believe that unconsented restraint use is ethically permissible, specifically when it's emergent and the patient is at risk of harming themselves through self-extubation, and there's obviously lack of capacity, and we need to act in their best interest. Agree that we need to use it when alternatives fail, that we need to inform and consent surrogates when possible, and potentially in retrospect. I think this is an important thing to think about. If we put patients in restraints and then a surrogate is present to explain to them why the restraints were chosen and ensure that the surrogate assents to that. And then frequent reassessment to determine need to prevent sort of prolonged use of restraints. And so that's my general philosophy on restraint use. And that's all I've got.
Thank you to all three of you, remarkably for all staying on time, which doesn't happen that often, so thank you. We have 19 minutes for comments and discussion. This is not a formal debate, but I would like to give our guest the privilege of the first rebuttal and response. So Dr. Gibb, the floor is yours, and then those who have questions and comments will ask for them.
Sure, thank you. So I think that I agree with majority of that. Can you leave that up?
Oh, I'm sorry.
Andy,
Yep, of course. Maybe. Yes.
So the really hard to see. So this idea about emergency. So I guess I've been called a permissive ethicist. I feel like my job is often to justify and help promote the appropriate practice of medicine. And I feel like in our current culture, the pendulum has swung from a paternalistic, physician-driven model of care to a very patient-centered model of care that I think is inappropriately undermines the autonomy of the physician, and so I feel like we are in the process of and in need of a recalculation whereby the moral agency and the autonomy of the physician or all healthcare providers is on equal par with the patients and their self-determination. And so part of that has been my perspective of expanding what the emergency treatment exception to informed consent includes. And in the place where I trained at UCLA, we took the approach of an emergency can be any urgent deterioration or harm, and harm being in the definition of harm being not only a deterioration but a failure to make an otherwise good outcome. And so I feel like I have a pretty expansive view of what an emergency is and how we can kind of shoehorn a lot of treatment decisions or diagnostic procedures into that exception to informed consent. I haven't heard the critical care unit referred to as an ongoing emergency, though, and I think that may be a step too far. I think that the justification for the exception to informed consent through the emergency is really an opportunity to provide medicine that would otherwise be consented to if we had either the opportunity to or the time to. And in the ICU, although there are certainly situations that arise urgently, I'm not sure that either of those justifications are at play. And so my fear is that if we treat the ICU as number one, just an ongoing, moderately controlled emergency, we will undermine some of the opportunities to get informed consent and get buy-in and reinforce the therapeutic relationship, this therapeutic alliance we have with the patients or their surrogates. So that's my first response. The other one's I don't disagree with the idea that patients at risk of harm to self in many situations ought to be restrained, although I'm not sure that justifies doing it unconsentedly. And then I guess those are my two quick responses. And I guess and not being a clinician, and I grant that I take a very ivory tower rosy view of the practice of medicine, and things are much easier to say, when I'm sitting behind my desk than it is at the bedside. But I have a hard time conceptualizing why including informed consent of restraints would be particularly onerous or disproportionately onerous. And I guess where I would specifically push back is the idea that the presumption of consent is applicable, because I'm not sure that everybody who gets intubated or has their loved one intubated connects the idea that they will also be restrained. And so, so on that condition, whether somebody would automatically assume that intubation, protecting an airway, therefore may also lead to consent, I'm not sure that holds.
So the question I'll pose to the group is one of consent versus disclosure, and the idea that per Dr. Cooke, there are some things that we do in the ICU that are just part and parcel of being in the ICU, right? You might have an extra line placed, you might have fill in the blank, and the question is, that is a part of a disclosure. When you're admitted to an ICU, there is a litany of things that may or may not happen to you. I think one argument can be made that consent is not necessary for restraints, but rather simply disclosure that that is a possibility, and that coming to the ICU requires that disclosure. So that's part one. Part two is that if we allow, or excuse me, if we require consent from either a patient or a surrogate, part of that requires us to understand what we would do if that is refused. So for example, if a patient who is intubated had either themselves or more likely their family member refuses to restraints, and that person self-extubates and is in respiratory extremis, what do we do? So in order for us to require that, we have to have a plan. And as ethicists will know, false choices are not appropriate, right? So we don't present something as an option when it's not really a choice that someone can make. So if we're not prepared to restrain someone against their will, what is the recourse if they are in respiratory extremis and without restraints in the termination of an ICU doctor will likely die?
Right. And so to respond to point A or point 1, I don't remember, whether it's disclosure is sufficient or whether it involves consent, that goes back to the idea of whether it's a basic liberty or not. And I think being able to urinate all over myself is not, I don't think, a basic liberty. And so it's a liberty, it's an imposition to have a catheter placed, but I don't think that rises to the level of a basic liberty. Whereas using my arms and I think that is something, it rises to a different level. So that's what I think the distinction is between a mere disclosure being sufficient and consent. But your second point is right on. And if we're not willing to accept somebody's refusal of an option, then it is a false choice, and that's deceptive, and there's a whole literature about why that is inappropriate. But I think also in that informed consent discussion, if the family member or generally not the patient, right? But if it's the family member or the surrogate decision maker who's refusing that treatment, then that places on them an additional obligation to either provide the treatment or provide the means of protecting the patient in some way. So it may require them to be at the bedside 24/7 to limit the harm that the patient unwillingly or incapably would be committed to themselves. Or it may be an indication that the aggressive level of treatment that we're contemplating, that the entire plan of care is actually not in line with what their fundamental goals might be. And it might be an opportunity to have that discussion about, is this really what you want? Because if you do want a curative plan of care, it requires a lot of different things. One of those may be physical restraints. And if any one of these other treatment options that are required to achieve the goal that you have stated are unpalatable to you, then maybe it's the goal itself that is not in line with what you actually want.
Comments and questions from the audience, please.
Where doctor 20 years of education and 10 years, 11 years of practice. They're completely in a case here where most specialized care on this to a, I don't know, mildly demented 8-year-old wife who was, is that fair to the patient? And some of this our responsibility because we're the physician.
I'm going to very briefly paraphrase for the folks listening on Blue Jeans. So have we gone too far in patient and family-centered care that we're shirking responsibilities of providers to simply tell people what needs to be done rather than giving them a laundry list of options for something that may or may not actually be appropriate?
Yes, I may. I'll comment on that. I think I'm in complete agreement with you, and I think that I do feel that the desire for preserving patient autonomy has swung in a way that has potentially compromised care in several circumstances. And the way I see this most commonly in the intensive care unit is I witnessed it among residents having code discussions with families where instead of offering a package of ACLS when a patient's heart stops, often the providers or the residents will offer the litany of things that is included in ACLS that by themselves may be ineffective when they're not delivered together. So I've been wary of that, and so I've tried to take an approach where I'm much more focused on spending time eliciting the patient's values and goals from the family, and then as a professional trying to recommend choices that are consistent with those values and goals. And I think that that's idealistic in many circumstances, but I think if one takes that approach where you value the role of the patient and the family is to bring in their perspective about their values and preferences, and the role of the physician is to understand the treatments, and it's also our job to help bridge that gap between those two. So I think that by focusing on values and goals, we can take away some of this focus on specific treatments, and I think that pertains to anything we do in the intensive care unit.
Follow-up question to Susan. So you deal with people in extremis all of the time in many different ways. And from your perspective at the bedside as a psychiatric consultant, how prepared or unprepared would you say patients and families would be to engage in a shared decision-making process regarding whether or not restraints are appropriate?
I think a lot of times they're not prepared, right? So let me clarify for a moment. I work in general care units, so I appreciate that the ICU is a very different beast, right, than we see in general care. So I work throughout UH, CVC, and adults and MOT. And so a lot of our behavioral restraints are the violent, right? And so the patients aren't prepared, the families aren't prepared to have that consent conversation before it happens. Usually we'll see kind of some cueing and some escalation before we get to the restraint episode, but still nowhere near prepared as a family and patient to have that conversation for consent. And then it's so unsafe that's the alternative that we have to go to because we've tried so many other things.
Other questions, please.
The conversation seems to be more specific than general about restraints. I think Sanjay Singh has this quote. I think part of what's happening here is I'm wondering if it's helpful to think about ventilation as inherently, because you can't move, you can't get up, you can't do the things that you normally do. Does that change the framing of the conversation in a helpful way? Because I think that is part of what I'm feeling this dissonance about as a physician. I think of those as one. We may have to do additional restraints to allow the initial intervention. But think about the intervention as an inherent restraint by itself. That may change the way that the conversation. I'd love to hear that.
Great. Again, very briefly for the audience, restraints are not necessarily what we do after we do the intervention, but rather can be part of the intervention. So a Foley and an ET tube inherently restrict someone's liberty. How do we take that into account when we're considering restraint policies broadly?
So just to respond briefly, I understand what you're saying, and I can visualize how a Foley might be a one-point restraint. But when we're looking at the nature of the intervention itself, the goal of the intervention, the intubation, is not to restrain. Although that is a known and expected sequelae of that intervention, whether that intervention is successful or not is not contingent upon whether it restrains or not. It's whether it supports and maintains the respiratory drive. And so physical restraints have a different justification. If somebody is physically restrained and they're still able to cause themselves harm, then that intervention in itself has failed. And so inherently, the goal of the intervention is to restrain, and the goal of the intubation is to intubate, or to provide respiratory support. And so I think there is a bit of distinction to be drawn between the formal and the material intentions of those interventions. I lost my other thought.
Yeah, I mean, I sort of like the general framing. I think it harkens back a little bit to what we've been alluding to, which is this notion that being critically ill, being on mechanical ventilation with respiratory failure, it comes with a package deal of treatments that we sort of as professionals believe are necessary in order to achieve the best outcome. And I think it's fair, although arguably, clearly, to include physical restraints within that package. But I obviously appreciate there are different perspectives. I will make one other comment related to your question or comment, which is that we have, in the modern ICU, we are attempting to try and remove the ventilator as a restraint. So there's been an increasing push to try and mobilize patients that are on mechanical ventilation because we realize it does improve sort of outcomes globally. So we're that thought of it as being a restraint may be waning if one were to articulate that as a strong argument.
One more question? I'm
So
sorry.
another response. So as I walk through the ICU doing ethics rounds or wherever I'm there, when patients are agitated and delirious and attempting to self-extubate and they are restrained, that doesn't strike me as an ethical problem. What strikes me as an ethical problem is when somebody is fully sedated and intubated and also on physical restraints, having no agitation, no obvious agitation, and not trying to self-extubate, but just as a matter of course, they are restrained as part and parcel of the intubation process. That strikes me as concerning, and that's really where the genesis of this discussion came from.
Can I make one comment about when we do the policy review and kind of write this language around restraint? That is part of the conversation and thought process that the patients in the ICU, this is part of their pathology, this is part of their treatment. And like Dr. Cooke said, it's kind of a package deal, right? And the physician up top said the same thing, like this is their expertise, this is their knowledge and training. And so that's considered when we write the language. And like I said, it's a unique situation. It is the emergency situation. I agree with that statement that it's moment to moment, hour to hour assessment of treatment and response. And so those things are definitely considered when we write the policy.
We are short on time. I want to thank all of our panelists, specifically our guest, Dr. Gibb, for being here. I think this really illustrates how we can have differences of opinion and some really thoughtful, spirited discussions of them from multiple perspectives. We don't always have to agree as long as at the end you agree with me. So thank you so much for being here. Thank you all for participating.